ideas. Our first speaker is Dr. Umang Mathur from New Delhi. He is the Chief Executive Officer, cornea specialist, and the leader of Dr. Shroff's Eye Hospital in New Delhi. And you're going to talk to us about a consortium you're leading.
Good morning. Lovely to be here. Great morning today. Visited the temple across. So I'll be talking about this Bodhya Eye Research Consortium that we initiated. If you look at the collaborations today, most of them are multicentric, and most of the data that we require today for research would come from multicentric studies. And with the consortium with large data sets, you can accelerate research to improve human health and well-being. Collaborations are important because data is dispersed. Today, especially after COVID, we've all learned that a lot can be done remotely. And so you don't really need to travel, and communication costs have come down. You can standardize data, and there's enhanced ability to share and exchange resources. India has a number of very large community-based organizations that are doing a lot of good work in their geographic areas, very high volume of patients. So a group of community-based hospitals, which are not really very focused onto research, but largely to service delivery. We've got together to work together towards research. If you look at the numbers that we see, it's about 1 million patients seen in the clinics. And this is not what we see in outreach, just in clinics. About 1 million patients are seen annually. 500,000 new patients, about 150,000 pediatric patients. And if you add what is seen in vision centers and screening camps, maybe over 12 million patients are seen with the network. Most of these institutions are up north and in central India. If you see the Indian subcontinent, especially the North Indian lineage, is related to Central Asians, Middle Eastern, Caucasians, Europeans, while the Southern Asian are considered to be from the Dravidian origin. This is pretty generalizable to most of the world. So the Bodhya Eye Research Consortium that we created is a proposal to have collaborative research among these leading eye institutions. And the data that we collect would be generalizable to the real world in a consistent, quality assured manner. So we set up an exploratory task force where there were some in-person discussions with the leaders of these institutions, shared goals, we defined the commitments that each of us had to have, and then we structured the BEC with a governance council, a scientific committee which sets research standards and guidelines for ethics and authorships, and there's also a conflict management committee. We anticipate sometimes they would be. There are subgroups within the consortium that meet every month. We have public health, pediatric, cornea, oculoplasty, retina, and so forth. These are joined by the specialists of those groups. Before we started, we did audit the quality standards in each of these institutions for basic demographics and how the data is kept in each institutions. About 10% of these files we thought had some missing data which were corrected. Each working group is led by a convener, which is the convener is chosen from each of these institutions. Every 3 months, the convener rotates. There are monthly meetings. Most of these are virtual meetings. And over a period of time, we've built a lot of trust and respect amongst each other. The quarterly updates are for the larger group, where all of them get to know what is happening in the entire consortium. Our first paper was published in BJO of MAC disorders, microphthalmos, anophthalmos, coloboma. These are congenital anomalies. Normally, most of us would see a couple of these patients, if at all, in a year. In our very first paper, we had 532 children with MAC disorders from 1 year data. And that is just to tell you the power of this consortium, that the rare diseases no longer are very rare. An important paper which Dr. Shailendra has written is the methodology paper for the Bodhya Eye Consortium. This is published, which is describes the methodology and how this data is generalizable to the real world. We have now publications from public health, pediatric ophthalmology, cornea subgroups, oculoplasty, glaucoma, and retina. And so far, we have already published 18 papers in peer-reviewed journals. If you look at the strength, there's, of course, abundance of data, as well as the pool of resources that we have amongst us as specialists. These are all high-volume clinics, and we've been able to show that we are able to work together in a good quality standard. Time is, of course, a limitation. All the service providers are very busy clinical setups. Lack of central monetary source for now, and lack of data sharing agreement. It's still a pretty loose consortium that we work together. Opportunities, of course, I think with this whole data that we have, we should be able to attract funding for research and administration. We are still using social media and other emails to do this work. I think over a period of time, we need to have better communication, and sharing medical data is becoming the security required for that needs to be put in place. But it started off as an idea, especially during the COVID time. I think we are very happy that we've been able to work together, all the subgroups working together. Consortium offers a distinct opportunity for members to advance scientific knowledge across various domains of eye care. And the population diversity in North India, encompassing heterogeneity and anthropological and genomic origins, allows findings from our studies to be somewhat generalizable to the real world, to the larger population. Thank you.
Fantastic. Thank you. Beautiful timekeeping. Do you notice that? 7 minutes, 50 seconds. Everyone else. Umang, come back. You're not going yet. Questions. This is really exciting. I mean, it's obviously taken a lot of work to get here, but I mean, I'm sure there are questions. And yeah, do I see a hand up at the back? Simon, please. Microphone.
Thank you, and congratulations. I'm Simon from Uganda. Congratulations. Lovely work. I wanted to know how you work as a consortium to sort out the ethics approvals for the publications.
So each of the institution has their own ethics. So they get the clearance from their own ethics committee. So right now, it's not like a central ethics committee. It is each institution has its own system, and they get the clearance from their ethics.
You might have mentioned it. I came 2-3 minutes late. I just wanted to know, since this is a fantastic idea, and how about the data? I'm sure does everyone use EMR? Was there any attempt to harmonize that? So I just wanted to get an insight on that.
So we did study that when we started, and it is not a uniform EMR, although about 4 out of 7 use the same EMR system, but it's not uniform yet. We generally would create a pro forma for each study, and there'll be a protocol created, and that is how we are doing it as of now. But it's not a centralized EMR. It would be great to have that, but it's diverse.
Great. Any final brief questions before we move on to the next talk? Yeah, please, Pushkar. Microphone behind you.
Hi, I'm Pushkar. My quick question is like, how is the data set up there? For example, do you have a system to link data across the institution? For example, if I go to one hospital one time and I have been to another in my 5 years' time, is there any mechanism to set up a unique ID and linking data across the system?
No, we as of now don't have something like that. Everybody is running their own institutions, and we are just collaborating very loosely like that. But they would be maintaining their own data within their institution. It belongs to that institution. They keep that data. It is not like a central repository where we are collecting all this data together.
Great. Thank you, Umang. Thank you very much. We're going